Okay. Good evening. We're all here. I'm with Assembly Member Linda Rosenthal. Hi, Linda.
Hey,
And
Brad.
we're joined by special guest, Dr. Erick Eiting, for our fourth town hall in a series on COVID-19. We've heard from infectious disease specialists, we've heard from mental health experts, and now we're going to hear from somebody who is on the ground in one of our great New York City hospitals managing this crisis. And let me just read a little bit about Dr. Erick Eiting, and then I'll throw it to Assembly Member Rosenthal. Dr. Eiting is the Vice Chair of Operations for Emergency Medicine at Mount Sinai Hospital, which includes the Emergency Department at Mount Sinai Beth Israel and the Urgent Care Center at Mount Sinai Union Square in New York City. Previously, he's worked as the Director of Population Health for Correctional Health Services at New York City Health and Hospital. So he has a public health background. And he has been the Director of Emergency Physician Recruitment. He was the Medical Director for Quality. He's done work at the Center for Transgender Medicine and Surgery, where he's had quite a high profile. He's an Associate Professor of Emergency Medicine. He's affiliated with the Icahn School of Medicine at Mount Sinai and the David B. Kreiser Department of Emergency Medicine. That's quite a lengthy resume. We're very honored to have you here tonight, Dr. Eiting. Thank you for joining us.
Thank you for having me.
So welcome to viewers. Good evening. Thanks, Brad, for our continued partnership on Sunday nights. And, you know, we're very grateful to you because we know how taxing, how exhausting this work is on you, Dr. Eiting. So we're glad that you could spend some time with us and with our audience. As everyone has heard, the deaths continue to accumulate. And as of this morning's press briefing by the governor, COVID-19 has claimed the lives of 4,159 New Yorkers, and 122,000 plus have tested positive thus far. Saturday's death toll was a stunning 630 people in one day. It just takes your breath away to contemplate how many people have been swiftly taken from us. But we did have a little bit of good news. We may be reaching a plateau, and I guess it's hard to define that, and we'll ask you about that later, but it seems like the numbers dropped a little bit in terms of deaths today. So Dr. Eiting can help us understand that. I wanted to dedicate tonight's event to Arlene Stringer Cuevas. She passed away on Saturday of COVID-19. She's our controller, Scott Stringer's mother, and she was a good friend of mine for decades. She was the first woman to represent Washington Heights in the city council. And in the 70s, everybody loved her, and we loved her a lot. And so I just want to, a lot of people have passed away, but this one's personal. So just dedicated to her and Scott and his brother, Carlos, Elise, and her grandchildren, Max and Miles, who she loved beyond all measure. We all want to comfort them and do something in her name. So thank you, Arlene, for everything you gave all of us. Dr. Eiting, I will ask you a question. How has COVID-19 impacted the emergency department of Mount Sinai? How has this onslaught affected your day-to-day operations? But what is, if you could give a broad view at first, what is the impact on your emergency department, your hospital, and how things work?
Thank you for the question. And again, thank you for inviting me to participate with you in this discussion. I think that we've been spending a lot of time really trying to figure out what the most appropriate response to this disease is. I think we're a little bit fortunate, unlike China, which had to sort of, figure this all out on the fly because they didn't have any other models to really look to. We were able to look at the experience that China had, the experience that Italy had. And so we did have a little bit of understanding, and that did give us a little bit of lead time. But honestly, the lead time we did have was not a lot. And so we really needed to make sure that we were working aggressively to scale up and prepare for this. And so essentially what we've done in our emergency department is a couple of things. We've worked with our engineers. And so we've essentially built off a walled off area where we're triaging our higher risk, higher acuity respiratory patients. We're sort of acting under the assumption that anyone who comes to the emergency department right now could have COVID-19, and many of them do. And so the ones who are coming in with respiratory complaints, even though it's flu season right now, and so there are plenty of people who may have some other respiratory condition, the assumption is, until proven otherwise, all of our respiratory complaints are COVID-19. So we're trying our best to get them into an area where we can isolate them. The area that we're using that was, from an engineering standpoint, was ideal to be able to isolate people was also our fast track area. And so we had to spend a lot of time walking through each room and making sure that, if we needed to, perform critical measures on these patients, if we needed to resuscitate them, if we needed to intubate them and put them on a ventilator, that our rooms were fully equipped to be able to handle the full scope of emergency medicine. So it's definitely been a long time in the works trying to make this happen. The other thing that we've been doing is just trying to make as much space available as possible. So we have a group of ambulatory physicians with Sinai who are staffing an ambulatory tent. And when we designed this, we had said, we know that there are going to be some low acuity patients who we don't want them to linger in the department, because the longer that they're spending in the ER, the more likely they are to get exposed if they don't have it already. And so we've developed this really fast triage, fast evaluation area. It's called a rapid evaluation tent. And the design is really to take some of those lower acuity patients who probably don't need much, but do need to speak to a healthcare provider and be able to move them forward and get them back home as quickly as possible. And the last thing that we've done is we've reconfigured our waiting room just to sort of set it up to be able to accommodate additional patients in a surge if we would need to. So there's a lot of work that's really been done to try and accommodate this and really get our hospital ready for the intense needs of this disease.
Okay, thank you.
Yes, first, viewers, please write your questions and we'll ask as many as we can during the course of this Facebook Live. But Dr. Eiting, just to follow up on your comment about lead time and what we had seen in China back at the beginning of the year, do you think we took advantage of that? Do you think our healthcare system was able to exploit that knowledge in advance? Because, I mean, you now hear about the basic things that we don't have, PPE, ventilators, gloves, of course, gowns, and masks. How much of a difference did that make, that preparation?
Yeah, and I think it's hard to say, because even the experience that we saw with China, it felt like there wasn't great dissemination of information that would have really been able to help us in the same way. I think that a lot of the lessons that we've really been able to learn are the lessons from Italy, but unfortunately we didn't have as much lead time there. And so I think it made it a lot more challenging. PPE, I think, is an ongoing issue. And I think that we've sort of thought about this, like, on a more theoretical level, like what would a disaster response look like? But we're also living in what I think is an unprecedented moment in medicine, This is a disease like none other that I have seen in my life. And so I think that whatever, lessons we could have learned earlier on, I think we still would be sitting here right now feeling as if we should have been better prepared for this moment.
Can you describe to us how many ventilators you have, how many you need, and what the situation with PPE is, just in terms of the scarcity of these resources, so the viewers can get a sense of that?
Yeah, absolutely. I mean, so we got a very large shipment of ventilators a couple of weeks ago, and we've deployed them all throughout the health system. So Mount Sinai has 8 hospitals within our health system. And so, we've been sort of trying to figure out what the need is, where they need to go. The State Department of Health has, very proactively asked for public reporting from all hospitals to understand, how many ventilators they have, how many they're using, what the PPE situation is. And I think, the design of that is really just to make sure we're not dealing with, a series of have and have nots. We want to make sure that we can try and distribute this as evenly as possible to all the people, and that we're, able to recognize, people who have different needs, and it shouldn't be the big players in the system are the ones who are able to leverage access, while some of the smaller players may not be able to have that same advantage. So we are doing all kinds of public reporting right now, just to make sure that everyone has the appropriate supply.
So just to final, so the ventilator shortage is being managed.
It's definitely being managed. I think the biggest question, the Surgeon General over the weekend commented and suggested that the next 2 weeks are going to be really challenging. All of the models that I've looked at for this disease suggest that it is going to get a little bit worse before it gets better. We were reassured by the decrease in the death count that we saw today. So maybe that's some suggestion that some of those models might be a little bit off, but I think that we're trying to be as prepared as possible. But I think that there are still a lot of concerns about the number of ventilators that are going to be needed. So we're still working very proactively to make sure that we have access to that as possible. It's still a work in progress.
It seems that Queens, for example, and the Bronx have more sick, a sicker cohort than, let's say, parts of Manhattan. At least the tragic numbers seem to be coming from Elmhurst Hospital, but for different reasons. So maybe you could go into that a little bit.
Yeah, absolutely. I mean, and so I don't know what it is about Elmhurst, Queens, that this disease just seems to have hit it so much harder than anywhere else that we're seeing in the city. I think that it's a couple of things, and why their experience has been a little bit what our experience has been in lower Manhattan. I think that part of it is we tend to have more hospitals in Manhattan than in Queens. So I think that's part of it. I think that there is a tremendous diversity to Queens. And I've seen some preliminary stuff out there suggesting that we are seeing some disparities in terms of the number of positive tests and the number of deaths. One thing that I had seen, a couple of things had gotten reported out in Michigan State. I believe it was 35% of people who had tested positive were African-American, and 40% of people who died were African-American, while their general population is about 14% African-American. Similar experience in Chicago, where there are a disproportionate number of the deaths were amongst African-Americans. I think we're still trying to understand what that means. But it feels like there is definitely a health disparities element to this disease, and we're trying to configure that into coming up with the best model for treatment.
But would it be that, for example, any hospital that's not Elmhurst, let's say, would have more access to ventilators and PPE, or is it just they have an overflow of patients and maybe some redistribution will be happening?
So I think it's more the latter. It's more that there have just been so many patients in that area for whatever reason is. And I don't know all of the details of Elmhurst, but what I do know is that on a typical day, they're seeing about 200 patients a day. And they have been reporting seeing as many as 400 patients a day. When I talk to most of my emergency medicine colleagues across the country, most people are like their volume is actually slightly down. And what we're seeing is a lot of your ankle sprains or, my allergies are acting up, or, some of your lower acuity emergency department visits, those people are staying home. Something about what's going on in Elmhurst, Queens, that is really driving up the volume. So there's an acuity to this. There are patients who are showing up in the hospital who are very sick, but there's also a volume piece that we're seeing that we aren't necessarily seeing in other parts of New York City.
I'm wondering, as a layperson, really, what do I know? But I would say that people in other boroughs ride mass transit more, to get to work. And, there's got to be some correlation between those several weeks of transmission and the ridership on the subways. Would you agree with that, like just general supposition?
Yeah, I mean, and I think that's part of the speculation. Also, when you look at the demographic of people who live in Manhattan versus people who are living in other boroughs, I think people who live in Manhattan are, more likely to live in single family homes, more likely to have second homes. I know there's been a lot of discussion about, people going to their second homes in Florida, or, people going up to Rhode Island, and then anybody with a New York State plate is getting pulled over by their police there. So I think that there are some places in New York where people are more likely to have been able to get out of New York City and just escape the density of it. As I think that there are a lot of patients in Queens and in the Bronx where they just don't have that same opportunity.
Well, following up on that, like the guidelines around mass transit use, which were a little confusing to begin with. And now we have this confusion around whether we should wear protective masks or use a scarf, as the mayor suggested.
Yeah.
What's the real story? If we're walking outside to walk our dog, for example, do we need to put on a mask? If we're jumping onto the subway because we have an emergency medical appointment, should we have a mask there? And generally, if we go to the grocery store, what's your take?
Yeah, so at this point, the CDC is recommending that people wear a mask. The guidance behind that. So, and there are a couple of different masks that we talk about. Like the most common one that we've been discussing in healthcare settings is the N95 mask, and that's really a mask to help prevent me, the healthcare provider, from contracting the virus from a patient while the virus gets what we call aerosolized, right? So if you're doing a procedure where it's being expelled at a greater volume and a greater distance in the air, you want to make sure that you have that N95 mask to make sure that you're being totally protected. The idea of wearing a mask, and the reason why they're saying that mask could be a scarf or a bandana, is there are a very large number of people with COVID-19 who will either have no symptoms at all, or they will have very mild symptoms. And there's still not enough known about those patients and about the disease in those patients to understand how likely it is that those patients are able to transmit it to other people. So when we're talking about wearing a mask and covering your mouth when you're on the subway, that's so if you have the infection, that you're not passing that along to other people. So that's really the guidance there.
So it's not because you may become infected from someone else on the subway.
It's going to be much less effective in protecting you from getting it from someone else, as it will protect you from transmitting it to somebody else if you're one of those asymptomatic carriers.
But people should still wear them.
Yes, exactly.
We see many people out there in the park, who are just ignoring that advice. So
Yeah.
it's good
And
to hear it again.
yeah, and in all fairness, I mean, I think it's a relatively recent, more formalized recommendation.
Right.
But some of the experience that they saw in China was that they did do more of a forced mask policy. I think that there were a lot of measures that they took in China that we would not do that in our country. I mean, like, there are measures that I think are a little bit beyond what we would be comfortable with in this society. But that is one of the measures that they had pointed to that they believe was able to help them get their epidemic under control.
Right, right. So you work to serve incarcerated patients in the New York City's public hospital system. And so I'm the chair of the Assembly Committee on Alcoholism and Drug Abuse, and I've been very involved with that population, especially making sure that they have access to their MAT drugs, which has been, it's an ongoing problem, and something I've been struggling to get done because they are among the lowest, least influential people in societies, people who use drugs and people who are incarcerated. And we've heard a lot about the situation in New York's correctional facilities. Can you describe some of the unique challenges that people who are incarcerated might experience? And do you think that there's a way to, there've been suggestions that both the governor and the mayor have released many people from those tight quarters, but if you'd give your expert opinion on that situation.
Yeah, absolutely. I mean, and I actually, have spoken to some of my colleagues out in LA County as well. And what people have been discussing is exactly, what you had just mentioned. I think we need to take a long and hard look about who truly needs to be incarcerated, who's actually, benefiting from being incarcerated, and whether their crime warrants that. Because I think that there's an additional variable in the equation here, right? I mean, so people who are incarcerated by their very nature are being condensed into a very small area. And there are ways to try and isolate people while they're incarcerated, but like isolation tends to have like long-lasting mental health impacts. So people who are put on isolation. So like if you're limiting the amount of time that they're able to socialize, or their recreational time. It can help to prevent the spread of disease, but it can be incredibly isolating in a time when I think it's really trying. So I think that is the important piece, is making sure that we're taking a long, hard look at who is being incarcerated, why they are there, and would it actually be more beneficial to think about releasing some people because of the gravity of the circumstances. And just to put it into perspective, I mean, so when I worked in the LA County jail system, one of the issues that we really struggled with is patients who are incarcerated are much more likely to have tuberculosis. And while in general, this is something that's, it's a disease that we get concerned about, but it's not highly transmittable. You have to spend a lot of time with somebody who has tuberculosis in order to contract it. But because you have that sort of condensed area, we just have to think about it a little bit differently. And trying to manage the logistics to make sure that our TB patients were properly isolated and weren't transmitting that to other inmates was incredibly challenging. And what we're looking at now is a disease that's much more transmittable. And some of the speculations are every person who is infected on average is going to infect somewhere between 1.5 and 2.4 other people with this disease based on interactions. And in an incarceration setting, you're more condensed, so you can anticipate that you would have more potential exposure.
It begs the question, doctor, whether incarcerated individuals should be provided with masks. Do you know of any penal systems that are doing that?
I don't know of anybody where they're providing masks to the inmates or to the prisoners. But I think trying to better understand the PPE needs for staff. So both for nursing staff, for physicians, and for correctional officers is something that we're still trying to better understand as well.
This is related to a
Again.
question from one of our viewers, Alan, who's gotten the first question to be asked. He asked how important masks are to immunocompromised individuals. For example, if you're going to chemotherapy, should you have ideally an N95 mask?
That's a great question. The recommendation isn't usually, because again, it's really only when you're around somebody who has or where you're having some kind of aerosolized procedure where you would truly need an N95 mask. That said, I'll tell you, in my emergency department, because again, we're still learning some of the lessons of this disease, we've taken the precautionary measures. So we said, while you're working in the emergency department, we want all of our doctors, all of our nurses, all of our registration staff, all of our patient care associates who do EKGs and empty bedpans and transport patients, all of our radiology technologists, all of our custodial staff, anybody who's doing any kind of work for more than just a few seconds in the emergency department is being provided with an N95 mask. So I think that's just sort of where we're at.
Well, I'll tell you something that I heard rather disheartening from a nurse who is unable to. They're rationed out a certain number of masks a week at a city hospital. The nurses have taken to the practice of using a hair dryer to try to disinfect the masks so they can use them over. Have you heard stories like that?
So I haven't heard using a hair dryer. I think that the most common practice that I've heard is people using the same mask throughout the entire day. And I think it's more before this came around, the most common usage of an N95 mask is if you were taking care of a patient with tuberculosis. And usually it was, you would go into that patient's room, do everything that you needed to do, ask all the questions, and then come out, and you would you would throw the mask out afterwards. And that would be one patient that you happen to be taking care of. We're just sort of surrounded disease right now. And so that's why people are saying you really should wear it the entire time while you're working in some of these, higher risk areas. But in terms of using a hairdryer, that I hadn't heard. There are some studies. So Harvard, for example, released something late last week, and they were talking about how they're using a hydrogen peroxide solution to try and sterilize and then be able to reuse masks. So that's a practice that it's still under investigation, but we're trying to understand whether or not doing that is sufficient to make sure that we're going to take care of the supply concerns that we have. And then also the University of Nebraska has also done some work looking at UV radiation and trying to understand whether or not that practice is sufficient to thoroughly protect people. I just think that we're using these masks at such an unprecedented rate. Like the burn rate is so high and something that we're not used to. And so there are very real concerns on the supply side of this. And we're seeing this, much sooner than the rest of the country. So what are everyone else's needs going to be, and how are we going to be able to meet those needs? I think those are still questions that we're trying to answer.
And people are being creative and making masks and giving it to hospitals, but can people really use those kinds of masks?
Yeah,
like the fabric
and it's a great question. I think everyone is really working very hard to try and step up and play their part and make a contribution at this critical time. And I love that people are doing that. Anything that gets donated to our hospital, to our health system, it's essentially sent to materials management. We would never put our frontline staff in harm's way by supplying them with materials that have not been approved by the FDA. So really our gold standard metric. But there are plenty of instances where we've been able to secure donations from people with equipment that is totally acceptable, is FDA approved, And we've been able to take advantage of that. In fact, we even received a donation. So the N95 mask, the 95 there comes because it's 99.5% of particulate matter that gets prevented. So there's an N99 mask, which is even an even higher grade, and you almost never use it, but we were able to get a donation of N99 masks. And then we said, hey, listen, this meets or exceeds the standards that we've created to try and protect our staff. So we've said that using those masks would be acceptable.
Great. And in terms of ventilators, maybe you could just explain how that works.
Yeah, yeah, absolutely. So we do when somebody is not able to sufficiently breathe on their own because they are that ill, we do a procedure which is called intubation, and essentially there's a plastic tube and it goes into in the mouth and into the trachea, and then that.
How far down does it go?
What's that?
How far down does it go?
It's just above what's called the carina, which is where your trachea separates into two areas.
The chest?
Branches. So yeah, so it's right about here. Yep. And
so it goes through your mouth all the way down inside. Okay.
Yes, exactly.
Okay.
So it goes from the mouth and then it goes into the trachea, and then we attach that tube. We will temporarily use a bag to help breathe, but then, for long term, we will attach that tube to what's called a ventilator. And the ventilator then helps the patient breathe. And there are all kinds of different settings that we have on a ventilator based on, what their condition is, what their lung function is, how well that they're, able to deliver oxygen to their tissues with the breathing tube. And so the ventilator has a bunch of different settings that we can place that really are able to maximize breathing when the patient is not able to breathe on their own. And so the part of the supply issue that we're sort of working through right now is making sure that we have enough ventilators. So you can sort of imagine how, like, if you had to attach a machine where essentially, like, every time you breathe, there's stuff that goes in and out. I mean, like, there are all kinds of bacteria in the air. It's once you've attached a ventilator to a patient, it's no longer sterile. So it has to go through a process then of sterilization. And so even when you have a certain amount of ventilators, not every one of them would be able to be in use. But as we looked to some of the modeling, so we looked to the experience of China and we looked to the experience of Italy, and we saw that that they ran short on their supply of ventilators because there were so many people who had such bad disease that they required ventilators in order for them to breathe. So I think the question that we're trying to figure out, or the issue that we're trying to work on, is make sure that we have enough ventilators in supply to address all of the needs. And I think that what makes it even more challenging is that this is a disease where it becomes very hard to what we call wean somebody off of the ventilator. So once you are attached to that machine, trying to take you off of the machine is more difficult than what it would normally be. And so there, it does pose all kinds of challenges. But I think this also factors into, I think it's really great that the state is collecting all kinds of information on, who has ventilators, what the supply is, what the use rate is, because we want to make sure that everyone is able to get access to all the equipment that they need. And the other piece of it too is that, even in my hospital, we have twice as many ICU patients right now as we do ICU beds. So we've actually created additional intensive care units to accommodate the gravity of this disease. And so, you just, in that scenario, you just need more ventilators. And so that's the continued.
Mm-hmm. And is 3 days like the point at which, if you're not weaned off, your prospects are not that good?
I think that there's a hard and fast 3-day cutoff, but usually after 3 days, we do have, like a fair amount of information that gives us a sense one way or the other how well people are going to do. And there are plenty of people who they will get intubated and they will have, long-term ventilator needs. And so even after they recover and they're just, they may be required to be on a ventilator. Or even some kind of supplemental oxygen needs that they may have. What we do know about this disease is it can be very bad for the lungs, and so
it destroys them, right? Essentially.
Yes.
In a layperson's word.
Yes, you are absolutely right.
Yeah.
Well, you'll be happy to know that one of the bills that Linda has been leading this effort for many years, and I joined her when I joined the Senate, was to ban the sale of flavored e-cigarettes.
Yes.
Yes. Are you seeing, anecdotally, I know there's no data yet, are you seeing any connection between e-cigarette vaping and outcomes with COVID-19?
Yeah, so we do know that people who are older and people who have underlying conditions are more likely to develop, a more severe form of the disease and are more likely to die. Underlying lung conditions is definitely one of those, but that's in addition to things like diabetes and cardiovascular disease. But all of those seem to paint the picture. And when you look at some of the respiratory illnesses that we see that are associated with vaping, and how even in young people, like they can develop significant lung disease. It definitely is a reminder that vaping is bad. It's dangerous. And I think this was a practice that was really kind of designed to try and help do some damage control with people who are having a really hard time quitting smoking. But that's just not the experience that we've had. When you have, people in high school who are addicted to nicotine because of vaping, it really kind of tells you something went wrong here.
Well, that's particularly if there's marketing to children. And
yes.
That's why we sought to ban, and we did ban in the budget, the sale of flavors,
yep.
which are designed to hook
exactly
young people. But, at the beginning of this pandemic, people said, don't worry, it's older person's illness. And now we've seen 30-year-olds pass away. Are the younger people who pass away, do they mostly have underlying conditions, or is it we've discovered new facts about how the virus attacks people, no matter their age?
I think that there's still so much about this disease that we really don't understand. And I keep telling people, like, this is like nothing that I've ever seen before. And just when you look at, some of the laboratory abnormalities, I feel like, a lot of these cases, you just sit there and you rack your brain and you're trying to make sense of it. And so I think that there's a big piece of this that we don't truly understand yet, and we're still trying to get to the bottom of it. But I think the scariest piece is, we're seeing plenty of young people who are getting very sick or even dying of this disease without any of those underlying conditions. And I think that's a big part of it that we really want to try and better understand. How can we do a better job of stratifying, and as we continue to work on trying to identify treatments for this disease, like who are sort of our higher priority patients who we would want to treat, and those would ideally be the ones who are at risk to decompensate, but we're still trying to figure out who those patients are.
Mm-hmm. Someone has asked about CPAPs being converted to ventilators. Can you explain that?
Yes. So, and I think that, people would be most familiar with CPAP because of a condition called sleep apnea. But essentially what the machine does is it helps to create what we call positive pressure. But it helps, I think the layman's way to think about it is it helps to open up your lungs a little bit more when you are breathing in, when you're inhaling, and it helps to prevent them from collapsing while you are exhaling. So it just helps the movement of oxygen and carbon dioxide in and out of your lungs. function a little bit more efficiently. So, I mean, like some of the principles of CPAP are very similar to what we're seeing in ventilators. So, you know, we have like in a time of short supply, you know, are there ways that you could sort of reconfigure a CPAP machine so that it would be able to function in a way similar to a ventilator? I think the other, you know, part of the conversation is, you know, like there have been stories, particularly out of Italy, of people where they had to, you know, share one ventilator for patients. While that's something that is, it's certainly possible, but every time you put somebody on a ventilator, there are so many different settings that are individualized. And so it's, you know, it's how much you weigh, how big you are as a person, how big your lungs are and how expandable they are, your age, how much positive pressure you would need to get in your lungs to make sure that you're able to oxygenate. And so the only way for it to work, for you to be able to share ventilators with multiple people, is you would have to have, you know, two people who require the exact same settings so you could put right next to each other. And so just to manage the logistics it's really challenging. I mean, and I think it speaks to, you know, people are you know, racking their brains trying to be creative of how they can address some of the supply side issues that we're seeing. But you know, like even trying to do that, I think still continues to pose challenges.
Have you used any split ventilators at Mount Sinai?
No. I mean, and to my knowledge, that's not something that we've used at any of our sites. You know, we definitely, I think we have concerns. We want to make sure that we continue to have ventilators in supply because, you know, again, it sounds like the next 2 weeks are going to be really challenging. But at least up until this point, we've definitely had all the ventilators that we've needed in supply.
So now that we're entering the phase where people have survived the disease, Mount Sinai has launched a campaign for antibody testing, right?
Yes.
And David and Richard are both asking about it. What is it? And is it effective in learning about who may have COVID-19 before? And does it have therapeutic uses that we're investigating?
Yes. So this is, and this is all still in an investigative phase. So we're still studying it, but there are some data out there to suggest that there's promise here. But essentially, every time we are exposed to a virus and our immune system goes and fights it off, our immune system then will generate antibodies. And there are two different types in particular that we look at in terms of immunity. There's IgM, which is, it gets made very soon after you're exposed to that, and it helps to sort of deploy all of the resources of your immune system to fight off the infection. And then there's IgG, which is your long-term immunity antibody, is the way that I like to think about it. And so we're looking at both of these two antibodies that get made after being exposed and successfully fighting off this virus. And the testing that's being done right now is to try and find people who have a very high amount of antibodies in their serum. And the reason to do this is because if you could, you know, a Nobel Prize was won many years ago off of, you know, being able to collect what's called convalescent serum. So you're pulling a bunch of antibodies from one person or from a bunch of different people. You're injecting those antibodies into a patient who has the disease, and then you use somebody else's antibodies to link to your immune system so that your immune system then can fight off the infection. So it's what we also call it passive immunity. And so, you know, there are some studies that suggest that this is an option for some people with very severe illness, but we're still in the phase where we're trying to collect enough antibodies. And so some of the testing that's being done, particularly with healthcare workers, is trying to understand who does and does not have antibodies. And then from there, it'll be looking at trying to collect as many antibodies as we can, and then trying to better understand how effective of a treatment this is.
So we'll post in our comments section the link to the Mount Sinai antibody study sign-up form.
Absolutely, absolutely. I actually got the antibody test this week, and my antibodies were negative, so I was a little bit disappointed.
So you've not been infected?
Yeah, I apparently not. I mean, my test was negative, so but I was so sure that just because we're seeing so many patients that have it, I was convinced that.
Okay, quick question, and I'll follow up with this because it fits into it. Sue Ellen is asking about reinfections.
Yes.
Are they happening or not?
Yeah, and it's a great question. I mean, I know that there is at least one case in China where it was a gentleman who was diagnosed, was put on isolation for about 6 weeks. Was completely asymptomatic, had been re-swabbed, had been retested. The tests were negative, and then again became symptomatic, and the test then was positive. So there are at least a handful of cases that suggest that reinfection may be possible. It's still just not clear what exactly that means. So even get a vaccine, for example, there are some people who will get exposed to the vaccine and they won't ever mount enough of a response to the vaccine to actually be immune. Okay, and it's not a large number of people that will have that, but it's a phenomenon that we know exists. And so could this person have been somebody who, for whatever reason, just is unable to mount a long-term immunity to this disease, and that's why he was reinfected? It's certainly possible. We don't know the answer to that question yet.
I had a staffer in Albany, and maybe it was 3 weeks ago, and he said, I am so tired. I have a stomach ache. I have chills, a fever. He said, go home, and he slept all weekend. And he was better, but he's an example of people you hear saying, I bet I had that a few months ago.
Yeah.
So they're all worried about whether, can I get it again?
Yeah.
And should they practice the same distancing? I guess everybody should continue to practice 6 feet apart.
Yes.
Being very cautious, right?
Yes, exactly. And even people who have been tested and diagnosed to have COVID, and they've recovered, should still practice those same, the social distancing, because it's because we don't truly understand the immunity piece of this, right? And so I think my biggest concern is that if we said, okay, you already had COVID, you have the antibodies, we already did the test, we've already confirmed that, so so we assume that you're immune. And then it turns out we don't understand the immunity process behind this disease. And so before we would go ahead and do that, I say, let's make sure that we understand the science behind this first before making any kind of recommendations or relaxing the restrictions.
So what about, well, I have one follow-up. So if someone has it, tests or believes they have it, what should they do at home if it's not bad enough to go to the hospital? What should they do if they feel they have it?
Yeah, so this is such a this is such a great question, because I worry sometimes that we may be sending mixed messages, right? Because what we've always told people historically is, if you don't feel well, and you think you might need to be hospitalized, or something's going on, go to the emergency room, right? And get checked out. The challenge with this disease is every time somebody who has the disease goes out into the world, there's the risk of being able to expose more people to coronavirus. And so the guidance that I've been providing people is that if your symptoms are mild, if this feels like you have the flu, right? And so it's uncomfortable, you're having the coughing and the congestion and the body aches and the sore throat, but you're able to eat, you're able to drink, you're still going to the bathroom as much as you normally would, you're not getting so short of breath performing your routine activities, then I would say your best bet is to stay home. And part of the reason is there are very few people right now who are doing any kind of testing for people who have mild symptoms. It's only the people who are first responders, who are healthcare workers, and then people who are being admitted to the hospital that are being tested, at least right now. Some of those recommendations may change in the future, but that's sort of where we're at right now. If you are having severe abdominal pain, if you're not able to keep down any food or drink, if when you first stand up, you feel so lightheaded that you're going to pass out, or you actually do pass out, if you are feeling so winded and so short of breath that you can't make it up a full flight of stairs without stopping, all of those things suggest that you have a more severe type of infection, which may require hospitalization. And so if you're having some of those more severe symptoms, you should absolutely go and get checked out.
And if you have milder ones, just treat it as you would a flu or a bad cold. Stay in bed, drink a lot, like that.
Plenty of rest. Exactly. Because we rely on our own immune systems to be able to fight off the any kind of viral infection. So it's really just taking care of yourself, getting plenty of rest, lots of fluids, and just sort of waiting it out.
Yeah, and it raises the question about the tests and the testing. In the best case scenario, with a novel virus as this is, we would have tested more, right, doctor, and had contact tracing and been able to isolate who actually had the virus initially?
Yeah, I mean, the public,
we were inundated and had no opportunity to do that.
Yeah, the public health piece of me wishes that we had been doing more testing all along. And part of it too is it's really hard to understand a disease when you don't understand the denominator. You don't understand the true number of cases that you have. And we know that this is a disease where so many people will have very mild infections or will have asymptomatic infections. We also, I think that, one area too that we're really trying to understand is looking at these infections in children. So, in Illinois, there was the first infant death of COVID that happened this week. But in general, this is a disease that isn't really impacting children. And, what does that mean? And what is their ability to be able to transmit the disease? But we don't really have that answer because we don't even know how many kids have the infection. And so, there is a piece of me that wishes that we were doing more testing and that we had been doing more testing all along.
You have quite a career in the transgender medical field. Are transgender folks, are you seeing any higher rate of vulnerability? And then connected to that, LGBTQ people, in particular those who are HIV positive?
So HIV positive are definitely a group of patients that we're particularly concerned about because of their weakened immune system. And so, we are having people take extra precautions, and I think that we would have a lower threshold in patients with HIV or AIDS to keep them in the hospital, even if they had more mild disease, because there would be concern that their immune system may not be strong enough to fight off the infection. In terms of your question about transgender, I haven't seen anything yet that suggests this. What I do know is that within the transgender community, there are so many different healthcare disparities. This is a population that is much more likely to have no insurance or to be underinsured, to have housing insecurity, to have food insecurity, to have employment insecurity. And again, everything that we're seeing about this disease suggests that there's a disparities component to this. So while I haven't seen any hard data to show that this is a community that's more disparately impacted by this, it wouldn't surprise me to hear that was true.
We have a question. We don't have very much time, but I wanted to ask this. What about people who have normal medical issues? they don't want to overburden the system that's already taxed, yet, maybe they felt a lump in their breast, or they feel they're having a heart attack, where they go to the emergency room. What do people in their everyday lives who usually go to doctors or emergency rooms, what should they do?
Yeah, I think that's a really great question. And so, when we sort of had to reconfigure our emergency department, I felt very strongly that, when we were decided to convert the waiting room, that should be an area where we're not sending respiratory patients, because I think you do have you need a space to be able to accommodate people so that coming to the emergency department doesn't increase the risk of exposure.
Right.
I think part of it is making sure that we're thinking creatively about how to address this issue. But I really just want to plug, so many of my colleagues have been doing telemedicine, and telemedicine is not something that's new to the field of medicine. I think what's always historically been very challenging for telemedicine is the reimbursement side of it makes it very challenging to be able to commit to. So, like that, I'm hoping that that's one of the positive side effects that we see as a result of this disease, is that we're just able to figure out telemedicine. But this is something that has worked really well. So we have a platform that's called Mount Sinai Now. And this is basically a virtual urgent care. And so you go and you download the app, you log in, and then you're speaking face-to-face with a medical provider. Many of the doctors—
You have to have insurance, an insurance card?
I'm sorry?
You have to have an insurance card?
You don't have to have an insurance card. There is a fee that you pay, but there are certain insurances that we accept through Mount Sinai Now. I don't have the details of what insurances they do accept, but I know that some of them are accepted. And this is an opportunity for you to speak with a doctor. Most of the doctors who are there are actually emergency doctors. And so I think it's really helping us, more effectively triage which patients would, benefit from just a telemedicine interaction versus trying to understand which patients really do need to be in the emergency department. And we identify those, we try and, develop pathways so that we can sort of fast track them in a way that you are minimizing the exposure. So if you're there because you need a breast exam, then trying to accommodate that. But I think the other piece is we're trying to triage people to places that aren't the emergency department. So if that's what you needed, then let's get you to a breast surgeon or a specialist who really can help you with the issue at hand.
Right.
I'll take this chance to ask my last question before Linda closes it out. First, let me just say thank you for everything you're doing. Thank you for this opportunity to talk to you and have these questions answered by our viewers, and for the service that you're giving the city now. It's incalculable. But with that in mind, I was wondering, what is the pressure that you and your colleagues are under? Linda and I were talking before we began that the social isolation that we all are experiencing and practicing also goes hand in hand with isolation of patients in hospitals. What kind of weight is on your shoulders as medical professionals when an individual cannot reach their loved one or family members or friends to make medical decisions about whether the intubation, should stop after 3 days? I mean, describe to the viewers the pressure you and your colleagues are under so we can appreciate all your work.
Yeah, and this is a really great question. I think something we're still struggling with, but just to put it into perspective, there was an older woman who I was taking care of recently, and she ended up expiring. She passed away before she was able to get a bed in the intensive care unit, and came in very sick. And so it wasn't a surprising outcome, but I think it's always devastating when you have to watch it happen. And the family ended up working with a bunch of our palliative care colleagues, and they really wanted to see the patients afterwards, which is something that we normally let them do, and they had to do it on FaceTime. And while I appreciate, the fact that we're able to do this dialogue right now, using that kind of technology, I think that in some of the most challenging and trying moments in our lives, to have to be able to do that through technology rather than being able to experience it in person, it's hard to watch. And so, this disease is certainly posing all kinds of challenges that we're still trying to work through.
Well, I'd like to say that if I had to pick a doctor, I would pick you, because I mean, aside from what I believe is a good bedside manner, you're so, I don't know, the way you convey information is very clear and straightforward. And I think throughout, this thicket of information that's contradictory and people don't know what to believe, I think you've really clarified a lot of it for our viewers. And we thank you so much for taking time out. And we want to make sure you stay safe. So please take care of yourself. I know your Hippocratic oath means that you will go there and do your best every single day. And we just want to make sure you take care of yourself and your colleagues, as well as all the patients that you administer to. So
Yes.
Thank you so much.
And thank you. I really appreciate having this opportunity. There's a lot of work that still needs to be done, and I'm committed to seeing this through until the end. But I really thank you, and I thank all of your viewers. This has been a really great opportunity. So thank you.
Thank you.
Good night.
Thank you. Good night.
Good night.